To go,
Excellent.
Sarah.
All right. Well, it gives me absolutely great pleasure to welcome you all to tonight's webinar. Very proud that the QNMU can put on this webinar for midwives. And I'm going to start by acknowledging that I'm coming to you today from the lands of the Yugara and the Turrbal people, as is Belinda, and that we acknowledge the traditional custodians of this land. And pay respects to elders past and present. I also acknowledge that many of you are coming to us today on the different lands from around Queensland. So please feel free to write in the comments the acknowledgement of the country that you're on. The QNMU also has a very proud history of creating safe spaces for webinars to be undertaken. So we have a statement of safety and respect for all our events, and that means that all of you have the right to feel safe and respected and feel heard. Our meetings and events are free from racism, discrimination and harassment. If at any stage you believe that behaviour is not acceptable or that you are experiencing any of those racism, harassment or discrimination, please let myself know, Belinda know, or Ebony know, and we will aim to fix that. I want to do a big shout out firstly to Belinda Mayer, who's my Strategic Research Policy Midwifery Officer, and also to Annie Barnes, who Belinda will do a bit more of a formal introduction to later. But I also want to acknowledge that on top of being proud of being able to bring you this webinar, we're very proud to have lobbied incredibly hard for the first chief midwife in Australia at a state level, which we're incredibly proud of, and that's Liz Wilkes in that position now. And also, I want to take this opportunity, whilst I'm a couple of days early, noting Monday is International Day of the Midwife. So without further ado, I think I have done the housework. Oh, there is a chat function. Part of the today's webinar is you will be able to put some stuff in the chat. Now, it's really hard when someone's presenting to see hands or chat. So when Annie is presenting, she may not be able to see those. Ebony and Belinda will handle any of those inquiries, and we'll look to get to questions at the end. So I think that is all of the housework that I need to do. A sincere thank you to you for your time in attending tonight's webinar. And Belinda, I'm going to hand over to you.
Thank you, Sarah, and thanks for taking the time to start our webinar off. I don't think Sarah will be able to hang with us, but it was lovely to have her start with the acknowledgement of country, so thank you. So tonight we have Annie Barnes, who is a lecturer at Griffith University. She's the course convener for prescribing for midwives at Griffith Uni. She's an endorsed midwife, a registered nurse and a lactation consultant, and we are very lucky that she has agreed, sitting in, I assume, cold Tasmania, to present pharmacology to us tonight. So thank you and welcome, Annie.
Thanks so much, Belinda. Yes, it is cold down here. I have a heater next to me, which is currently off, but you may see me reach over and turn it on partway through the presentation. Depends how the temperature out there drops. I'll also apologise ahead of time. We have 3 dogs living here in this house, and one of them called Wilberforce, who's named after William Wilberforce, the great campaigner for slavery. William Wilberforce did great things, and our Wilberforce, is hoping in his lifetime to see maternity care reform. So he gets very excited if I'm online, and sometimes he barks in the background, so apologies ahead of time. He's just there barracking for us, okay? So we're doing great things, and, as you said, Queensland's really leading the way, and it's really hard after having lived in Queensland for many years to suddenly find myself, not so suddenly, living in other parts of Australia where we haven't made quite as much progress, but we keep hoping. And Wilberforce is here with us, barracking for us, and hopefully we can all make it over the line eventually. So I'm going to share my screen. I've got a PowerPoint that I'm going to work through. I come to you from the land of Lutruwita down here in Tasmania, and I will share this PowerPoint, and as has been said, I may not see your questions, but we can get to those at the end. There'll be plenty of time. Okay, so I'm going to share my... So we're going to talk a little bit about medications and pregnancy and breastfeeding tonight. And there's some really unique things about breastfeeding and pregnancy and how medications interact. So just for those of you who need a bit of a refresher, we're just going to go through a couple of little bits. Remembering that I never studied chemistry at school, so this is almost a layman's take on pharmacology. Okay, so one of the things we have is pharmacokinetics, which is the effect that the body has on the drug. So there's certain things that need to happen to a medication to get from outside the body to inside the body where it's actually going to have an effect. So first of all, there's absorption. So it might come into the body through us taking it orally, through an intramuscular injection. Obviously, IV is a fairly direct way for it to get into the body. It might be a cream that comes in through the skin. However it comes in, it's got to be able to get to the part that it's meant to act on. So that's distribution. It moves around the body in certain ways. It's got to be metabolized. And one of the things about metabolism is that enzymes in the liver work in different ways in different bodies. So there's some people who metabolize things more quickly than others, and there's certainly things during pregnancy which will affect how things are metabolized. So one of the things that you might have heard in your career, particularly if you've been in nursing as well, is about someone who comes in and they get given perhaps Panadine Fort and they come back to you saying, that's not having any effect, it's not working, I'm not feeling any pain relief. And they often get labelled as a drug user. In actual fact, it can be the way that they metabolize and that they can't actually turn that codeine into something that works for them, the morphine that might work for them. So that's something to keep in mind. If you've got someone who's saying that the medication's not working, it may be just that their body is not actually metabolizing it in such a way that it's actually going to make a difference to their pain levels. And of course, excretion, mostly we're excreting obviously the urine and feces. So there's some changes in pregnancy that affect those 4 factors about how the medications get into the body. So during pregnancy, the gastric pH is reduced. So you're going to find that medications that rely on that acidity to be absorbed might not be absorbed as well. And for that matter, gastric emptying is changed. So you will find that maybe a medication that's meant to be absorbed in the intestine is not going to be absorbed as well, or it might take a lot longer to absorb because that medication is moving with food a lot more slowly through the gastrointestinal tract. And the other side of it is too that a medication may have more of it absorbed because it's actually been designed to work in a particular way. And the changes of pregnancy have meant that it's actually sitting in the gut for a lot longer, or the bowels a lot longer, and it's not actually being excreted as quick as you would expect. So you might find that you've got actually increased levels in the blood, which is obviously not the plan. So distribution-wise, we've got increased blood volume. So a medication may be more dilute than it would be in that non-pregnant body. We've got plasma protein concentrations being reduced. A lot of medications, or a percentage of medications, are protein bound once they're in the blood. So there's not as much actually in the blood circling around at any time freely, but that might be reduced with those, that might be increased because you've got maybe less plasma proteins in the blood. Again, hepatic blood flow increases. So you're going to see the blood circling through that liver and maybe things getting metabolized in the liver a bit more quickly. And then, of course, you've got changes to excretion as well, which may mean that a medication actually gets excreted from the system quicker. So a medication that you're expecting to be in the body may actually be removed from the body. So pharmacodynamics. So that's the effect that the drug has on the body. For example, chemical, physical. Chemical could be like, for instance, when we give it something as simple as an antacid. So it's changing the acidity of the stomach. Physical, something like lactulose, where we give something that draws water into the bowel to make, it's a physical thing that's happening. It's actually making those feces move quicker because we've actually made them more full of water. And then enzyme-mediated actions and cell receptors. And that's one of the major ways that medications have an effect on the body. Things like oxytocin, for instance. We use that regularly in maternity setting. It actually attaches to the oxytocin receptors, and that's why it works. So the thing is about pregnancy, most drugs cross the placenta by passive transport or diffusion. And as you would know, if you did study chemistry at school, the thing about diffusion is it goes to the higher concentration to the lower concentration. So because the placenta is a semi-permeable membrane, you are going to have whichever concentration is the highest, whether it's the fetal circulation or the maternal circulation, it's going to pass to that lower concentration. And with altered physiology of pregnancy, it means that we actually have changes in how all that works. So things that affect the passage across the placenta is the size of the molecule. So large molecules are not going to pass across, and heparin's an example of that. Lipid solubility and ionization, as well as we've said, protein binding, and that increased maternal drug concentration, as I said, where you've got a higher concentration in the maternal blood. If it's circulating freely, then you're going to get a higher concentration passing to the baby. Something to take into consideration, of course, is oral bioavailability. When you take a medication, and we'll talk about a bit more when we're talking about breastfeeding, but not all of what's taken even makes it to the blood system. So molecular weight, as we said, is of relevance. Weights less than 500 Daltons will cross a placenta easily. Now, many medications are bigger than that, but the smaller medications are more likely to pass to the baby. The amount of the drug, so a small amount of drug is maybe not going to be such a problem because only a small amount can ever pass to the baby. And membrane permeability, so that increases with gestation and placental efficiency. So the more, like when you get a baby who's maybe got a placenta that's not working as well, one protective factor at least is it's not going to get as much medication. So fetal and maternal blood flow. So I've just got this diagram here, and you can see this is fetal circulation, and it does differ from circulation once someone's born with those functions that help the blood. Like blood doesn't actually need to go to the lungs much in pregnancy, so only 8% of the fetal blood actually goes to the lungs from the heart, because it doesn't need to be oxygenated, obviously. It's been oxygenated in the placenta. And those lungs, as you know, are not blown up in utero. So the blood comes in, and you can see down the bottom corner there from the placenta on the left, and it goes up. And normally you would expect it to go to the liver, but a lot of it actually bypasses the liver and goes straight to the inferior vena cava. So medication is not going to be necessarily metabolized in that liver immediately. It's going to go to the fetal circulation first. So again, protein binding, where a drug is protein bound in the maternal circulation, a limited amount's available to the fetus. However, where the drug's protein bound in the fetal circulation, there may be more pass to the fetus by diffusion. The fetal pH during labour changes. As you know, we spend a lot of time monitoring babies in labour these days, and sometimes we have to do more invasive testing, and we know that the pH can change, particularly in second stage of labour. So a decrease in the fetal pH may increase transfer acidophilic agents. I was actually trying to find what was an example of acidophilic agent or drug, and I could get up with LSD. So obviously that's not what we're talking about. If you want to find an example, you could let us all know, and we'll find, I'm sure if we went through every drug, we'd find out whether they're acidic or not. But anyway, I diverge. Hypoxia alters the blood flow, so less blood going to the liver and the kidneys, as we know, like a baby will favour those vital organs. So that means effectively less medication would be metabolised and less would be excreted, and albumin binding may be reduced. So the thing that has become apparent over the years as we've started getting more and more medications is that we have medications that are teratogens. So these are medications that can affect the baby in an adverse way. And this picture is out of a great textbook. It's also been repeated in a very recent textbook called Pharmacology and Midwifery, which was released this year, and it's a great text for midwives specifically. Now, this graphic works a little bit differently from your normal 40 weeks of pregnancy, because it goes from ovulation, because obviously there's nothing happening in those first 2 weeks before ovulation. So this week 1 and 2 is basically from ovulation. And any teratogenic medication at that time is probably just going to cause maybe an early abortion. So there's not going to be an ongoing effect on the baby. It's going to just abort, and no one will know the difference. A woman might get a slightly heavier period. But it's those weeks 3 to 8 that you can see in that picture there that actually make the big difference when it comes to teratogenic medications. And we get all sorts of things like those neurotube defects, get heart defects, the cleft lip. So all those things are happening in those early days. The cleft palate can be affected by medications that are given during that time. And as you get further through the pregnancy, there can be some things that happen, but they're less likely. So those are really the vital weeks when it comes to medications. But the difficulty is that in those early weeks, a woman may not know they're pregnant. And this is where we run into difficulties because we give medications based on what we know about the medications. Once the thalidomide disaster happened in the early 1960s, it kind of changed the world as far as what we're prepared to give to women of any age, really, at any time, when they're in the childbearing ages, because we don't know when someone's pregnant necessarily and when they're not. And we do know that some medications do have quite disastrous effects on the fetal development and the fetal life. So back in the 1960s, when thalidomide happened, we changed the way we did things, and the development of the TGA, the Therapeutic Goods Authority, came out of that. Medications have to be approved for use in Australia, and we have a lot more information. I don't know if you're aware of the TGA consumer medication information sheets or the product information sheets. They're really useful tools to give us lots of information, and all of that's come together out of that disaster in the early 1960s. So we now know that we now have collected information to know that there are effects from medications, but our information is still very limited because we can't actually do trials on women who are pregnant. So when we talk about trials of new medications, they might be developed. Some genius will come up with, I can cure this disease. So before it comes to human use, it'll often be tested on animals, which is great. That gives us some information about what might happen. But animals work differently from humans, and so obviously that information won't be all that we need to have. So in that first phase, there might be 10 to 15 people. A limited number of people will be given limited range of doses to give us some idea about how that medication will work in a human body. In phase 1 there, human pharmacology, a few more people will be involved in the trial. Still small numbers of healthy volunteers, and they'll work out a bit more about the pharmacokinetics and the pharmacodynamics and how it's going to go through the body, how it's going to work, how it's going to be excreted, and what is likely to happen. Then we have the next phase where there might be 100 to 300 people. And we'll start to see whether it's going to work on what we want it to work on. The next phase, phase 3, is 300 to 3,000. And in this phase, we're going to get a lot more information about the drug. Does it actually do what you want it to do? And we decide that it's safe. So the next stage is thousands of people. And this is when it's gone out to the market. It's being used as a medication. And we start to pick up whether this medication works, but also the side effects. There's ways to go onto the TGA website to actually report side effects. And this is where a lot of information is collected. The thing about this information that's collected, it relies on the individual to actually go on and do it. So the doctors are usually the people that report these side effects, but they're busy, as you know. I don't know if you've ever tried to get into a GP in a hurry. It takes a while. They have very full days, and the question is whether they actually have the time to be going on. And it's not an easy process, I'm told. It can take 20 minutes to half an hour to report a side effect of a medication. So much as many will do it, there might be others that just don't have time. So we don't have a full picture. But what we do have are these categorizations which are put together to give us some information about medications. And as you can see, most of it is post-marketing information. So that category A, which is considered the safest category in pregnancy, is drugs are taken by a large number of pregnant women and women of childbearing age. No proven increase in occurrence of fetal damage or other proven harmful effects on fetus. So paracetamol is something that would fit into that category. Obviously, a lot of people have taken it during pregnancy. There's no reported side effects, and it's considered a very safe medication. And so you go through and you could assume that A is safer than C, and that B1 is safer than B2, and that B3 is safer than D. But the problem is with these categorizations is that some medications are only a problem at some stages of pregnancy. So there might be a category A medication, but you can't give it at a certain time. Or they might be a category D medication, but that's only in that first 8 weeks that we talked about. And after that, they're fine. So it doesn't give us a full picture. And the FDA have actually gone away from using this categorization system. And Australian Medicine's Handbook has also gone away from using it. And they prefer to give individual information about medications. When you go to the listing for each medication, you'll see the safety in pregnancy information rather than a category. So some examples here is tetracyclines can cause teeth staining. So they're not given after the first trimester. So doxycycline is a category D. Ibuprofen is a category C medication. Now that's a medication that we use a lot, but we don't use it in pregnancy because it can cause malformations in early pregnancy and premature closure of the ductus arteriosus when given in the third trimester. Now, nitrofurantoin is a category A medication, which when we go back, you can see that category A is taken by large numbers of pregnant women and children of childbearing age, and there's no proven increase of fetal damage. However, nitrofurantoin should not be given after 36 to 37 weeks due to the risk of hemolytic anemia in a G6PD individual that may not, the mother may have it or may not have it, but the baby may have it and not be diagnosed. Obviously, it's not born yet. So you can see that these categorizations can be quite problematic. They give us some information, but they don't give us the whole picture. Okay, so this is an example of, I've just taken this straight from the Prescribing for Midwives course site, so I give all credit to the person that wrote this page. So you can see, we do get women with fulminating preeclampsia who come into our unit. They might have just had a bit of a high blood pressure, and before you know it, all sorts of traumatic things are happening before your eyes, and doctors and medications are everywhere. But what's happening for this woman? She's got increased vascular permeability and peripheral edema, decreased circulating blood volume, reduced glomerular filtration rate, oliguria, abnormal liver function, and reduced plasma proteins. And these can be changing very rapidly. She's got a baby on board, and we've given her all these other medications. We've given her betamethasone because she's probably preterm. We're giving her Magsulf. We're giving her prostaglandins if we need to induce the labour, and oxytocin as well. We're giving her IV fluids. Metoclopramide is an antiemetic. Hydralazine for hypertension. And we're giving an epidural as well. And so we've actually poured all these medications into someone who has substantially differing physiology at this moment in time. And she has a baby on board who, as you saw, is also got different physiology, maybe suffering from hypoxia and taking all these on. So we do work with quite complex issues in some women. The breastfeeding, we're up to that now. Again, it's passive diffusion, and that's the dominant pathway for drug transfer. So again, if a woman has a really high level in her blood, then the baby's more likely to. And this is affected by the timing of a feed as well. A woman may have a medication, which, she has a good level in her blood, but the baby sleeps for 6 hours. And so by that time, the woman's actually metabolized the medication, excreted the medication, the baby goes to the breast and it doesn't get very much. On the other hand, the baby obviously is feeding on demand. It may decide to feed 2 hours after she's had the medication, and that happens to be the peak time for that medication. So again, we have, information. Again, we have the problem about women who are pregnant, same as the women who are pregnant in that we don't do research on women who are breastfeeding. So we don't have all the information that we need. So what are the factors that might influence drug transfer between a woman and her baby when she's breastfeeding? So, as I said, the medication concentration in the woman, the maternal plasma protein binding, stage of lactation. So in those early days, the junctions are fairly open and medication can get through fairly easily before the milk comes in. But it's not a big issue because the woman probably only producing a matter of mils of colostrum. So although the medication may pass fairly easily into the milk, the baby may not be getting very much at all. Again, the molecular weight of the medication, lipid solubility, the milk pH compared to the medication acidity, medication oral bioavailability. So some medications we give intramuscularly or IV, however, because they don't actually get absorbed from the gut. So a baby may take a medication from the woman, but just excrete it because it's not actually going to be absorbed. Again, the age and the physiological maturity of the baby, and of course the volume of milk intake. If the baby is only taking small volumes of milk, it's not going to get a lot of medication. And what happens is that the breast milk might have a high level of medication, but it's actually going to diffuse back into the woman's blood volume maybe before the baby gets it. So it might have initially been high, but it's that diffusing situation where over time it decreases in the milk. And you do hear women getting advice about, if they're put on antibiotics to take baby off the breast or only feed at certain times. And it's not really ideal information because we actually want babies to feed on demand. For older babies that are on solids, not such a big deal, but our newborn babies are needing to feed on demand. So it's all about trying to pick medications that are the safest for a baby. I think I've probably covered most things on that slide already. Talked about the protein binding. Okay, so we've come up with another little table here. It's been put together by Thomas Hale. And again, because we don't have that information, we don't have those studies, we don't enroll breastfeeding women in drug trials, we don't really know what's safe and what isn't safe. So Thomas Hale has come up with these risk categories, which are widely used. And you see them mentioned on the TGA information sheets to help us work out, is this drug appropriate to give to this woman at this time in her breastfeeding journey? So L1 is considered compatible. So it's a drug which is taken by a large number of breastfeeding mothers without any observed increase in adverse effects in the infant. Controlled studies in the breastfeeding women failed to demonstrate a risk to the infant, and possibility of harm to the breastfeeding infant is remote, or the product is not orally bioavailable in an infant. And then you go down to L5, which is where things are considered hazardous. And so they've demonstrated significant and documented risk to the infant based on human experience. So, and then there's everything in between. So obviously, if we're talking about medications that we would like to prescribe, we would stick with the L1s as much as possible. So just some examples. Paracetamol is an L1. It's got an oral bioavailability of greater than 85%, and its half-life is 2 hours. So it's actually excreted from the mother's circulation fairly quickly. Ibuprofen is also a category 1 once you've given birth to the baby and you're breastfeeding it, is category 1 now. It's got the oral bioavailability of 80% and a half-life of 1.8 to 2 hours. So these are good medications to use in a breastfeeding woman because they do pass through her system fairly quickly. And here's some other examples. So we've got oxycodone, which is obviously widely used after a woman's had a cesarean section. It's a category L3. It's got a 60 to 87% oral bioavailability and a half-life of 2 to 4 hours. So it's not too bad. It's going to go out of her system fairly quickly. Not ideal, obviously, but we have to balance the needs of the mother here, which obviously are substantial when she's got a surgical wound. However, tramadol, which we still see used in settings in maternity, is L3. It's got a half-life of 7 hours. So that's actually going to stay in the woman's system quite a long time. And potentially that baby could have a number of feeds in that 7 hours. So it's something to take into consideration. There have been reports of adverse outcomes in babies who have taken a breast milk where the woman's been given tramadol, and you can see the potential there for difficulty if that baby is getting quite a load of that over that period of time. And remember that it's fairly immature, so its liver's not as mature, particularly if it's slightly premature. So it's not going to be managing that load as well. Some other examples, nitrofurantoin is at L2. It's got the oral bioavailability of 94% and a half-life of 20 to 58 minutes. So that is most risky in the first 4 weeks of life because we don't know if a baby has that G6PD deficiency. So that can cause hemolytic anemia in that period of time. After that, there's probably not much reported where it's a problem. Amoxicillin, that's another one we use regularly. It's a L1, half-life of 1.7 hours. So that's, those sort of medications are safer. The ones with the shorter half-life are the sort of ones that we want to use as much as possible. And just another example, Ibidilol, something that we use regularly in maternity settings. L2, oral bioavailability, 30 to 40%, fairly low, half-life of 6 to 8 hours. Now, I haven't done a round in a medical ward for a very long time, so I can't say that I remember ever using clonidine, but it's another antihypertensive. And you can see there it's an L3, but it's got a half-life of 20 to 24 hours. So you'd see that that would be a very unsuitable medication to use in the maternity care setting. So how do we know what medications are useful to use and which ones aren't? So Hale's Medications and Mother's Milk, hopefully wards where you work have got a copy of this. It's a great resource. It gives us lots of information about the medication's half-life, about how they're excreted, and whether they're, what category they're considered in the breastfeeding woman. Australian Medicine's Handbook is a great resource. It's, as you can see, Australian. It's peer-reviewed, so it's different from perhaps a MIMS, which is just information gathered from drug companies, whereas Australian Medicine's Handbook is actually peer-reviewed, and so you look at the information, it's regularly updated, and hopefully, I find it a really useful resource. And as I said, it actually gives a description of why or why not a medication is suitable in pregnancy. The TGA product information sheets, now these are information sheets provided by pharmaceutical companies about their product as part of their approval for use in Australia. So the information might be overlaid. So anything that could possibly ever happen is likely to be on those sheets. And in that respect, the Australian Medications Handbook is probably a better resource. It's more filtered information. But the TGA product information does give you the breastfeeding category also. Sorry, the pregnancy category. Therapeutic guidelines is another really useful resource, and you won't have access to that unless you do through a hospital that you work at or an organisation you work for. It's quite expensive to subscribe to, but it gives you information on what medications are useful for what stages of pregnancy and breastfeeding. Okay, so there's also state drug information services, and if you read the article that was linked tonight, it gives you information about the different services in the different states that you can get information. Most states have a chief pharmacist who can give you that information, can actually talk you through what medication you might be thinking of giving a particular person. The Women's Hospital in Melbourne has that breastfeeding and medicines guide, and Briggs Drugs in Pregnancy and Lactation. There's also an app that you can download onto your phone, which is really handy. It was once called LactMed, and that sort of went out of vogue. I was really upset when I got a new phone and I couldn't download it. But then I found this one. And you can see that you've got a list of medications alphabetically that you can pick from. This is an American website, so obviously that's paracetamol that we're looking at there. And you can see all those buttons that you can click on to get more information. You can get the effects in infants, effects in lactation, and alternative drugs. So if you think, oh no, paracetamol's not useful for me, you can see what other drugs, and we might go for ibuprofen there. So the thing is, in all of this, is we have to weigh up. We don't have all the information that we want or would like to have. We don't have good research trials that we can rely on to get information. What we do have is record of history that we can rely on. We do have to weigh up the mother's needs. For instance, we know that SSRIs can be problematic for babies. They're more likely to have difficulty transitioning at birth. However, when we look at the woman's mental health and the possible effects that we can have on her mental health if we stop medication, then we have to weigh that up and say, well, in this situation, it is much better for this woman to be taking this medication, and we'll deal with any particular risks there might be later. So it's always that weighing up, is this a good medication? Which is better? Is it better for the baby, better for the mother? It's quite a difficult decision, as you can see. Okay, that's it. Any questions? I'll stop sharing.
Thank you, Annie. That was really good. That connection between your knowledge around pharmacology and clinical practice. I found, and I mark papers for you and do all sorts of things, and I just found that really, really helpful.
Thank you.
Does any does any well, midwives, you all love it when it's like, oh yeah, this really helps me in my practice. Does anyone have any questions they want to ask? You can either type it into the chat or put your hand up. It doesn't matter what the question is. Someone's writing. While they're writing, I'm going to. I was interested around the tramadol, Annie, because it feels like these days tramadol is seen as a softer medication to give women than the oxycodone, and yet it's actually more affects the baby more, which is that I thought that was really interesting.
Well, there have been reports of quite dire outcomes, but they're so minimal, they're so small.
Yeah.
I know a lactation consultant at our hospital has questioned the anaesthetist, because it's often the anaesthetist that prescribe it coming out of theatre.
Yep.
And they're not concerned about it. I know lactation consultants are, so it's that balance, isn't it? And we're probably looking at it from a different angle. They're looking at the overall history and reports, and we're looking at that 7 hours of half-life and that baby and that risk, so that it's not a drastic thing, because obviously there would be a lot more reports if it was, but it has been noted in the literature. So it's not ideal, but I don't think we're going to get rid of it.
I'd love to hear your view on. For me, I've been a lactation consultant since 1991, when I was still pregnant with my son. Second cohort in Australia, and I've done it and then let it slide, and then I've done it again and let it slide. One of my big worries is that, first of all, what I see lactation consultants in general doing is what I always did anyway, as a passionate midwife, supporting women breastfeed. And I'm just wondering, because you could be a lactation consultant so long as you fit the criteria of, spending time with women and all that sort of stuff. How do you feel about lactation consultants in general, if they're not midwives, like a private practice midwife or just a registered midwife or a midwife with endorsement? The difference between their knowledge of that. Do you think there's enough of a requirement or enough governance around if a lactation consultant should know medications?
I actually like it is part of when you do the IBCLC exam. Obviously, remember that too. That you do need that. You do need that information. I do think, having done the study to be a lactation consultant, I certainly did learn things. But I think a passionate midwife knows her stuff, and I get concerned when we start seeing the need for referring to a lactation consultant all the time. I think it's great that we have them on the ward, because they fill in all the gaps that we can't fill in when we're busy doing all the things that we do.
Yes.
So, but I think if we didn't have the patient loads that we have, we'd probably be able to do that extra bit of learning ourselves.
Yes.
And I think that, often the lactation consultants spend a lot of time in the nursery with those preterm babies who need that extra input. But I think that's knowledge that we should all have as midwives. I think that that's our bread and butter, working in the postnatal space, that we really need to upskill. And I think that's the reason I did the lactation consultant exam. I've been a midwife for many years. I didn't do it till 2019, partially because when I did my master's, it had a lactation subject. So I thought, well, I may as well, go down this track.
Absolutely. Yeah.
But I think when I was doing the study, because I'd been passionate about breastfeeding, I don't think I learned a lot, but there certainly were some things that I did pick up. And I think that understanding about medications is probably a really important thing to realise what we're doing. And
Yeah.
I don't think I was really aware of those lactation categories before I did. I just assumed that everything the doctors ordered would be fine, you know. But then I
Yeah.
realized actually, as a midwife, we can actually have that bit of extra information and understand ourselves. So it's that extra step of understanding when we
Yeah.
go to give
Yeah.
something. And I think that's the importance of um, keeping midwives with enough time to do their jobs and enough time
Yeah.
to people like
Yeah.
you who are making sure that we have appropriate workloads
Well, I'm
to
trying.
make
I'm
sure we
trying.
can do our job well.
Exactly, exactly. And I guess for me, the issue around lactation consultants is that there's no real regulation around it. And it's not that I think everything has to be regulated, but if we're employing a lactation consultant who is or is not a midwife, what is the governance around them having that knowledge around?
Mm,
Because we're talking pharmaceuticals in particular. I
mm,
mean, I remember many years ago a woman that was admitted to one of the very rare in Australia uh, mums and babies wards postnatally, for she had postnatal
mm,
psychosis and she had to go on some heavy duty medications. And I had to counsel her around that, and I had to counsel around that she was on pretty heavy duty medications and she really couldn't breastfeed, and she was very passionate about not immunising her baby. So her
mm,
first baby was fully breastfed. She didn't immunise the baby, but she recognised the fact that this baby wasn't getting breast milk. So therefore, so it was just a really complicated conversation as a lactation
mm.
consultant. And yeah, I guess I'm just throwing out there as a discussion. It's interesting because I worry more and more that as our workloads are like this and
Mm.
breastfeeding becomes into this, that we're
Yeah.
losing a big part of who we are as midwives.
And I think that's what's happening. I think because of the business on our ward, we have more babies that need various tests. You know, we've got
Oh,
more
yeah,
babies being born before they physiologically would have been born, so perhaps not as ready for this world. I remember, it was nothing to have 6 women on a morning shift, and it wouldn't be too bad.
yeah,
These days, if you
yeah.
had 6 women on a morning shift, you'd be like, I'm counting the minutes to the end of the day. I'm never going to make it. Because we had so few babies needing blood glucose levels. We had so few babies getting jaundiced. We had so few babies that weren't ready to feed, but now we
Yeah.
have those babies that have come those few weeks earlier, and we know every week counts. And
Yes.
so I feel like as midwives, yes, we are relying more and more on lactation consultants.
Yeah.
And I know the ones that I've worked with have been
Yeah.
amazing, and mostly midwives, I think, as well. And so that we become reliant. But I would get concerned, like you, that we would lose our skills as midwives if we give everything off to lactation consultants. So
Yeah.
when I used to work at Redlands Hospital in Brisbane, I used to actually follow, if I had to ask the midwife that was the lactation consultant to come and help, I'd stay with her. So I picked up the skills that she had, because I thought, well, there's no point me getting her to come into the room, solve this problem, and then the next time I get the problem, I need her again.
Yeah.
So
Yeah.
I feel like we can learn a lot that way too.
Yeah. 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 Sorry, I've moved that into the lactation consult
Yeah.
side, but yeah, I'm very passionate about that and the issues around, what we give up and look, yeah, 6 months. So Abigail's just said in the chat. Can you see the chat, Annie?
I'll just see if I can see it now.
She said those ratios are still the case for private maternity, 6 mums and buds on morning shifts. And Abigail, I hear. And look, anyone who wants to go off and talk, you're more than welcome, because this is not just between me and Annie, because we have these discussions many times when we get the chance to meet. But this is a huge problem, and this is a big win that we've had in Queensland, in that babies are now counted. It doesn't mean that our ratios are right at the moment, but it means that the business planning framework, which is our framework for hours per patient day, has to now include babies, whether we have ratios or not. So it should start shifting things. But you're absolutely right. What we found through surveys of our members is that the moral distress, and I've been there doing some agency, the moral distress of going, okay, I've got 6 patients. I'll be lucky if 2 had a normal vaginal birth without any intervention.
Well, that's the other
ter-
side. Yeah.
at term, like they actually weren't induced either. And then you've got all the complications that go, and you've got this mother, and this mother that are having breastfeeding issues. You've only got so much you can do in 8 hours. Who do you prioritise? And it's an awful thing, and that's why so many midwives are leaving. And that was a huge component of our Count the Babies campaign, was because if midwives can come to work and do the work, like spend the time with women with their breastfeeding, and while they're breastfeeding, and you're making sure and you're staying there, you're not just racing in, helping them getting on, racing off to the next thing. While you're staying there, you're doing all that other stuff. How do you settle your baby? How do you know if it's hungry? How do what do their poos look like? We had the 1-800 someone online might know this better, the child health line. They were saying that they were getting, on day 3, day 4, they were getting phone calls from mothers going, "Oh my God, my baby's poos have changed colour. What's going on?" And they were normal. It's because we're just, time to care is a huge thing for midwives and for nursing, and it's something that QNMU and all the unions the ANMF bangs on about all the time. Sorry, I got on my whole horse a bit then. I get a bit excitable.
Yeah, no, it's true. I think, and as midwives, we're passionate about what we do. That's why we do it. I mean,
Yes.
we get up early, stay up late, work overnight, have
Yep.
our family going off to a party or gathering on the weekend while
Yep.
we're sitting in birth suite because no one was induced today, but I'm stuck here anyway. So like we give up a lot as midwives, whether we're on
We
call
do.
or not.
That's
Even if
true.
we're working shift work, predictable shifts, there's still things that we're going to miss out on. And we study hard and we learn a lot and we do our
Yep.
CPD and we
Yep.
dedicate our lives to the people that we care for. And I think
Absolutely.
it's so rewarding. Like no one would deny how
Yep.
rewarding it is to have a midwife. I'll tell you a funny story in a minute, but I think there's those sacrifices that we make, but there's the reward on the other side. But when you're feeling like you can't do your job, that's when
Yep.
it's really, really hard. And that's
Yeah.
where the distress comes in.
Yeah.
But I will tell you a funny story. My mother, when she was in a nursing home, I used to go in and ask her more about her life. You finally get to that point where you've got time to sit, nothing else to do, and you can talk. And she told me one day, she said, she grew up in Penrith in New South Wales, in the ward in the 1920s. And she said, I said to her, "Mum, you were born at home, weren't you?" She said, "Oh, yes, we had a midwife for every area. The midwife would come when someone was in labour, pre-contraception, so that probably happened a lot."
Yeah.
And she said, and one day, Lily next door was in labour the same time as Marge over the road, she said, and there was only one midwife for the area. So we had to go and get a midwife from another area. And you know what? She said things went pretty well for Lily considering she had a midwife that she'd never met before. And I thought, well, we didn't need to do all that research, did we, on continuity of care?
Nice.
Because obviously people knew back in the 1930s that if you didn't have a midwife that you knew, it might not go as well. So
Yeah. 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 Yep. Absolutely. Now we veered off because we do get passionate about, and look, anyone's welcome to jump in on this. This is not just
yes,
meant to be a discussion
please
between me and
do.
Annie. Does anyone have any questions around pharmacology, or medicines, or anything like that? While we've got our expert online with us, I would reiterate what Annie was talking about. Uh, each state and territory, unfortunately, does have its own Drugs and Poisons Act, and you just
Mm,
need to understand the variations. Queensland's is pretty good,
mm,
and I was midwifery advisor at the time, and we fought for midwives to prescribe to their scope of practice. So
yeah,
midwives in Queensland are not under a formulary. We just have to S3 4 eights. We can prescribe if you're a prescriber. Now, if you're under the EPA, which is another thing, and that's any publicly employed midwife works under the Extended Practice of Authority, which kind of replaced the drug therapy protocol. And while it sounds terrible because it says extended practice, and we kind of argued against that because it's not extended practice, it's just that's around the Director General's ability to say midwives can do this. It's around him. It's not around our practice. And it actually expands what we can do under the drug therapy protocol. So if your hospital and health service is still working under, what is it, where the doctors standing orders, if you're under standing orders or if you're having to wait for doctors to prescribe things for you, you need to look at all HHSs are under the EPA, which means that there's certain things that you do not need to get a doctor to prescribe for first. You don't have to get him to write in those things. You can do that. You can do the Synto, or you can start antibiotics. There's a range of different things that midwives can do, and that's different to what Annie has talked about today. And if you want to go back, we have through the CBD portal, I think Ebony is our background guru, is that we had a webinar with a great obstetrician on the difference between the Safer Baby bundle and every week counts, because there's a lot of conflict around that. And he did a really brilliant David Elwood webinar for us on that. If anyone wants to look at that, that's still relevant. And then Ros Donnellan Fernandez, who Annie and I both work with, who's a professor in Griffith University, she did a presentation on the EPA, the difference between the EPA and an endorsed midwife, and it's pretty heavy because Ros knows the legislation, but that's something that you can actually go back to and have a look at those Am I correct, Ebony? They're there somewhere that people can go back to and find. And
yes, definitely the Ros one is in the CPD portal. I'll just have to check about the first one.
I think David was after Ros. But anyways, one of those ones that we did last year. They're really good webinars. And thank you, Annie, for today. This has been I think this has been really good webinar. I hope everyone online has found it really interesting and related to their practice, whether you're a prescriber or not. It's something that we all have to know, because we have to know doesn't matter if it's been prescribed, we have to understand and know what we're giving to women, and the consent that we're getting from women when they are getting receiving medications for themselves or their babies.
And that's the thing. It's like that tramadol. Yes, it might be prescribed, but just being aware that you'll be keeping a closer eye on that baby than, we're going to watch every baby, obviously, but that baby in particular, we need to keep a closer eye on it. We need to be sure that it hasn't had an adverse outcome or effect.
So there's lots of thumbs up and thank yous, Annie. And if you'd like to finish off with anything, I just really, really thank you. You're sitting in Tasmania and you've done this for us. I hope I didn't guilt you into it. No, I didn't guilt you into it. You're lovely.
No, the thing is, Belinda, when you know a really awesome midwife and they ask you to do something, of course you're going to say yes.
Oh,